Hello and welcome everyone. Today's presentation is on the vasopressor sparing action of methylene blue. Now, shock is an acute circulatory failure causing inadequate oxygen delivery to the cells, triggered by various pathophysiological mechanisms like cardiogenic, obstructive, distributive, and hypovolemic states. The common types of shock in ICU are septic shock, which is a distributive type of shocks, accounting for 62%. Cardiogenic 16%. Others like obstructive and other causes of vasodilatory shocks are less common. The treatment of distributive shock is very difficult. It focuses on managing the hypotension, ensuring adequate systemic and microcirculatory flow and tissue oxygenation. Intravenous vasopressors, that is norepinephrine, are used to maintain a MAP above 60 to 65 millimeters of mercury. High dose of vasopressors can lead to adverse events such as dysrhythmia, peripheral ischemia, increased myocardial oxygen consumption, hypercoagulability, immunomodulation, GI peristalsis alteration, and extravasation. Some patients may not respond to the first-line norepinephrine treatment. Now, there are some catecholamine sparing agents. Due to the risk associated with catecholamine vasopressors, the interest in the catecholamine sparing agents to achieve hemodynamic targets and to lower the dose of catecholamine drugs is being researched. These agents aim to reduce the norepinephrine doses by 50% or more than 4 hours without reducing the patient's baseline MAP. Examples include vasopressin, steroids, and angiotensin II. Methylene blue as an adjunctive agent is being seen. It is considered that it is a catecholamine sparing agent in distributive shock, but its use remains controversial. This video will summarize the current evidence of methylene blue as an adjunctive agent in critically ill patients with distributive shock. So coming to what is shock, the pathophysiology and its treatment. The definition: originally shock in 18th century referred to a sudden worsening of the patient's condition after major trauma. Currently it is emphasized as an imbalance between tissue perfusion and cellular oxygen demand. It is characterized by hemodynamic features, that is decrease in tissue perfusion leading to cellular and metabolic disturbances. The primary goal to treat shock is to enhance the tissue perfusion by restoring the perfusion pressure to the vital organs, ensure adequate oxygen delivery, addressing the microvascular alterations when possible. Now, what are the types of shock? We have already dealt with it. The hypovolemic shock caused by significant loss of intravascular volume leads to reduced preload, stroke volume, and cardiac output. Compensatory increase in the systemic vascular resistance to maintain the perfusion is seen. The next is distributive shock, which is characterized by severely reduced systemic vascular resistance and an abnormal distribution of microvascular blood flow. It occurs with normal or increased cardiac output, and in septic shock specifically, it is triggered by patient body's response to the pathogen-associated molecular patterns and the damage-associated molecular patterns. Results in a vasodilatory shock and increased capillary permeability, leading to capillary leak, vasoplagia, and absolute or more commonly relative hypovolemia. Now the treatment. The treatment remains fluid resuscitation, that is the initial approach. Fluids are administered first to increase the preload, stroke volume, and cardiac output. Fluid administration must be carefully managed to avoid negative impact over and under resuscitation. The next is SOSD mnemonic rule. That is salvage phase, administer fluid generously initially, then optimize, use hemodynamic monitoring to tailor the fluid administration. Stabilization phase, where you remove the excess fluid once the patient is stable. Finally, you de-resuscitate. Next is assessment of fluid requirement. Dynamic tests like pulse pressure variation, stroke volume variation, along with fluid challenge techniques are used to evaluate the fluid needs. Vasopressor therapy. The role of vasopressor therapy is very important because it corrects the deficit in the systemic vascular resistance, thus restoring the MAP perfusion pressure and the tissue perfusion. The optimal MAP is 65 to 75. Norepinephrine is the first choice, and Some patients may not respond to norepinephrine, requiring alternative. The alternatives in non-responders is vasopressin or epinephrine. Epinephrine use is limited by the risk of splanchnic vasoconstriction and tachyarrhythmias. Inotropic agents like dobutamine may be added to increase the cardiac output but have concerns regarding direct organ damage and harmful effects. So the microcirculatory consideration, the hemodynamic coherence loss is seen, which occurs when the macrocirculatory resuscitation does not necessarily improve the microcirculation, especially in the early shock. Microcirculation is a complex network crucial to adequately deliver the oxygen to the tissues. So what microcirculatory complement include the endothelial cells, the glycocalyx layer, the vascular smooth muscle cells, and the various cellular components like platelets and cytokines. The function of microcirculation is heavily influenced by local stimulus, endothelial response, and the state of the glycocalyx layer. The sepsis impacts the microcirculation involving all the components, leading to a dysfunction in the regulatory function and a mismatch of the regional oxygen supply and demand. Next is nitric oxide. The role and function of nitric oxide is very vital in microcirculation. Nitric oxide serves as a crucial messenger in various physiological processes, including the gene transcription, mRNA translation, and vascular tone regulation. In vasodilatation, the nitric oxide diffuses from the endothelium to the vascular smooth muscles and the bloodstream, causing vasodilatation, inhibiting the vascular smooth muscle proliferation, platelet activation, and leukocyte adhesion. Activation of the SGC, that is the nitric oxide activates soluble guanyl cyclase, leading to production of cyclic guanylyl monophosphate, and activation of cyclic GMP dependent protein kinase, resulting in muscle relaxation of the blood vessels and vasodilatation. Now, there are various isoforms of nitric oxide synthase. First is the neuronal, that is NOS or NOS1, which is found primarily in the brain and spinal cord, involved in learning, memory, blood pressure regulation, and abnormal NO signaling is linked to neurodegenerative diseases. The next is NOS3 or the ENOS, that is endothelial. It is located in the endothelial cells, plays a role in inhibiting platelet aggregation, leukocyte adhesion, and regulating the cardiovascular function. The next is inducible NOS, that is NOS2. It is calcium independent, induced by inflammatory cytokines and pathogen associated molecular patterns, that is PAMs, leading to significant increase in the NO production. Next is NO in distributive shock. So increased NO levels are seen in sepsis, anaphylaxis, and cardiac surgery, contributing to the mismatch between the macro and the microcirculation. Excessive NO synthesis results in overproduction, particularly to the inducible NOS, which promotes vasodilatation, hyporeactivity to the pressure agents, leading to hypotension, hypoxia of vital organs, and progressive organ failure. The dual effects of NO, while NO can be cytotoxic, it also has protective effects such as countering oxidative stress, preventing apoptosis, and exhibiting anti-inflammatory activities. The next is the clinical implication. The impaired NO biosynthesis that is seen during the late phases of shock is because of the ENOS is downregulated while INOS is increased, affecting the vascular endothelial function. Now, NO cyclic GMP pathway activation, its excessive activation is linked to distributive shock, but NO also has beneficial effects. So that is the reason why it is also produced in sepsis. Now, selective inhibition and NO scavenging. Current research focuses on selecting the inducible NOS and inhibiting it, and also using NO scavengers to target the microcirculation impairment, preventing excess NO and preserving the essential NO function, which is important as a protection in sepsis, and aiming to more precise therapeutic targets in distributive shock management. So where does methylene blue fit in all of this? This was the background. Now we will see how methylene blue is fitting in all this picture. Now, coming first to the pharmacodynamic and mechanism of action. The action on guanylyl cyclase, the methylene blue binds to the iron heme moiety of the SGC in the vascular smooth muscle cells, blocking the action, leading to decreased cyclic GMP levels and reducing the vasorelaxant effect. Now, NO scavenging and inducible INOS inhibition. Methylene blue can scavenge nitric oxide and can selectively inhibit the inducible nitric oxide synthase, affecting the NO pathway involvement in vasodilatation and microcirculatory dysregulation. So, this was the mechanism of action. Now, let's see what is the pharmacokinetics. After an intravenous administration, the methylene blue concentration peak at 30 minutes with the onset of action of 30 to 60 minutes. It is a high volume of distribution and is significantly protein bound. It is excreted through bile, fecal and renal routes. The half-life and infusion. The terminal half-life is 5 to 6 hours and continuous infusions can extend its therapeutic effects for 48 to 72 hours. So you need to have a very clear idea regarding the pharmacokinetics before you can start an infusion, especially on the onset of action, which is quite delayed, and the context sensitive half-life, which can be extended, especially in continuous infusions. The next is clinical application. Commonly, it is used as a dye in investigation of GI and urinary symptoms and in oncology patients for sentinel lymph node detection. It is effective in treating methemoglobinemia caused by benzocaine use and facilitating the conversion of methemoglobin back to hemoglobin, also used for congenital methemoglobinemia. Other clinical condition where it is used is priapism, neonatal hypotension, and as an anti-malarial agent. However, the concern for us is the use in vasodilatory shock. So in vasodilatory shock, a therapeutic dose, that is a bolus dose of 1 to 2 milligrams per kg, is typically administered over 10 to 20 minutes. Sometimes you can extend it up to 1 hour also. So we have already dealt with the mechanism of action of the drug. Now, regarding its application in vasoplegic shock, there is an increased evidence supporting the methylene blue use in various vasoplegic states, that is sepsis, anaphylaxis during hemodialysis, cardiac surgery, liver transplant, and end-stage renal disease due to unique mechanism of action in the NO pathway. Now, coming specifically to methylene blue in septic shock, there have been various studies, and the summary is they randomized controlled trials and observational studies have demonstrated that methylene blue can significantly increase the MAP in septic shock patients. Methylene blue has led to notable increase in systemic vascular resistance, suggesting its effectiveness in countering the vasodilatation in septic shock. A meta-analysis has shown the ability of methylene blue to decrease lactate levels, indicating an improvement in the tissue perfusion, metabolic function in septic shock patients. Methylene blue administration facilitated the reduction and discontinuation of catecholamine vasopressors, showing its potential in managing refractory hypotension in septic shock. Dosage and timing. There is a variability in the dosage that has been administered as well as other parameters. Now, methylene blue is often used late in the treatment of refractory vasodilatory shock. However, there may be a window of opportunity for methylene blue's effectiveness, suggesting early administration, that is within first 8 hours of septic shock onset, which might be more beneficial in patients. Regarding mortality benefit, despite improvement in the hemodynamics, methylene blue has not been consistently associated with reduction in mortality in septic shock patients. A retrospective analysis identified responders to MB through a positive hemodynamic response and a non-responders with significantly better survivals, possibly due to less severe tissue hypoxia. Now, the effectiveness of methylene blue and the likelihood of positive response can be linked to a degree of tissue hypoxia and metabolic acidosis. Early intervention with methylene blue before the development of profound ischemic changes could be more beneficial. So regarding the clinical implication, methylene blue has shown that it has evidence to suggest it is more effective as an early adjunctive therapy. Considering the variability in patient response, treatment with methylene blue should be tailored, taking into account the timing of administration, the patient metabolic and hemodynamic status. More research is needed to establish the optimal dose, timing, and patient selection criteria for methylene blue use in septic shock, as well as clarifying its impact on long-term outcomes. Now, regarding the role of methylene blue in other type of shocks, this is a study which have been done in various vasodilatory shocks, where we can see initially we had a lot of case reports. Later on, we have some prospective trials also. We have already discussed this. Regarding the role in non-septic shock, but other type of distributive shocks, here we can see that methylene blue has been studied for anaphylactic, drug-induced, and undifferentiated shocks. In those cases, most evidence comes from case reports and series showing benefit in survival and reduction in catecholamine use. Observational studies and undefined shock types, publication bias, and considerable profoundness like steroid use, shock progression limits can be a challenge in interpreting these results clinically. Regarding the safety, methylene blue is well tolerated. Common side effect is temporary blue discoloration of skin and urine, flushing, dizziness, nausea, pain, and chest and limb. Potential risks are worsening of the arterial oxygenation and reduced PF ratios due to inhibited hypoxic pulmonary vasoconstriction. Mesenteric vasoconstriction at high doses potentially compromising blood flow can be seen. Local cutaneous necrosis with prolonged peripheral infusions can be seen. Lower pulse oximetry reading due to methylene blue spectral absorption can also be detected. So there are also dose-related toxicities, that methemoglobinemia at doses more than 8 milligrams per kg, hemolysis, chest pain, hypertension, severe intravascular hemolysis, hyperbilirubinemia, and death at very high dosages. Serotonin syndrome, the risk is increased if it is combined with antidepressant agents, and cytochrome P450 interaction, because it affects hepatic metabolism, potentially leads to drug interaction and has a narrow therapeutic range. Specific population where we need to be careful is pregnancy with the risk of fetal hypoxia. It contraindicated in G6PD deficiency due to risk of hemodiatic anemia. Caution should be advised in hepatic and renal dysfunction due to altered MB metabolism and excretion. So to summarize, what we see here is the mechanism of action of methylene blue. Here we can see that there are various ways by which the nitric oxide can go up. Most likely in sepsis it goes up because of the inducible NOS. So this is the endothelial part, this is the muscle cells. So how methylene blue acts is it blocks the guanyl cyclase, thereby reducing the cyclic GMP levels, which thereby reduces the dephosphorylation and makes the muscle constricted. So this is how methylene blue acts, and because it also has scavenging effects, it can be beneficial in patients with septic shock. So the role of methylene blue needs to be more defined, and we need more research to find its proper dose, duration of action, and exactly at which point we should start the usage of methylene blue. Thank you.